Okay, so if you're staring down a major nursing exam, maybe that big final or, the NCLEX itself, that feeling. It's just
Hmm.
information overload.
Absolutely. It feels like you're drowning in facts.
Exactly. And you can't just memorize definitions. That's not going to cut it. You have
Yeah.
to understand how to actually apply these concepts, especially in like a high stakes patient safety situation.
That anxiety is definitely real. And when you're tackling health assessment, foundational
Hmm.
concepts, well, the sheer volume of acronyms, theories, it can almost paralyze your critical thinking.
Hmm.
So our goal today really is to give you the ultimate shortcut. We want to provide a structured, really high-yield review.
Okay.
The aim is to force that shift,
Mhm.
moving away from just passive memorization towards active clinical application, thinking like a nurse.
That's the mission for this deep dive, then. We're taking all those essential concepts from those foundational chapters, chapters 1 through 10, plus those key study guide facts, and we're synthesizing them.
Right. Connecting the dots.
Connecting the core engine of the nursing process with patient safety, how to prioritize, and all those assessment tools you absolutely have to know. This is basically your masterclass in the NCLEX mindset.
Well put. So we'll kick things off with the professional foundation, sort of defining the nursing role. Then we'll dive into that core engine clinical reasoning. We'll
Okay.
definitely spend a good chunk of time on safety and urgent assessments, super critical. And then finally, we'll apply all that knowledge to the detailed assessment areas: vitals, pain, cultural awareness, development, and mental health.
Sounds like a plan. Let's jump right in with what defines us as nurses. Hashtag 2, foundational nursing practice and rules.
All right, so when we talk about the foundation, the bedrock of professional nursing, we almost always start with the American Nurses Association, right? The ANA.
Yep, the ANA. They really set the boundaries for our practice.
So what are those four broad goals, the ones that every single nurse, no matter their specialty, is working towards?
Okay, these four goals are really fundamental. First, we promote health. Seems obvious, but it's core. Right.
Second, we treat human responses to health or illness. Now, notice that wording carefully. It's the patient response, not the illness itself.
Ah, that's a key distinction we need to keep coming back to.
Absolutely. We'll definitely revisit that. Third, we advocate for individuals, families, communities, even whole populations. Advocacy is a huge part of our role.
Mm-hmm.
And fourth, we prevent illness. And it's also really worth mentioning that the ANA Nursing Scope and Standards of Practice, that's the document that legally spells out the who, what, where, when, why, and how of nursing practice. It defines our scope.
Okay, and that prevention piece, that's immediately testable material, isn't it? The 3 levels of prevention.
Definitely. You need to know these, Cole.
So let's break them down. Primary prevention first. How do we make sure we don't mix this one up with the others? What's the key?
Primary is, I think, the easiest to grasp because the person is, for all intents and purposes, completely healthy at this stage. The goal is simple. Stop the problem before it even starts.
Okay, proactive.
Exactly. It's proactive health protection. So the classic examples you see on exams are things like education, teaching people not to smoke, talking about seatbelt laws,
Right.
or the most common one cited, vaccines. You're preventing the disease from ever getting a foothold.
Got it. So healthy person, stop it before it starts. But then we move to secondary prevention. Here, the person might actually have a condition, right, even if they don't know it yet.
That's the subtle but critical difference. Secondary prevention is all about early diagnosis and, crucially, prompt treatment. The goal is to stop it from developing into a more dangerous stage.
So they might be unaware.
Often, yes, the intervention happens when a person is unaware that something might be brewing internally. That's why routine screenings are the perfect examples here. Think annual mammograms or routine blood pressure checks maybe at the pharmacy or a health fair, or glucose screenings for people at risk for diabetes.
So we're catching things early.
Catching things early. That significantly changes the outlook, the prognosis.
Okay, makes sense. So if primary is stop it before it starts and secondary is catch it early, then tertiary prevention must be.
Tertiary kicks in once the illness or condition is already established. This is often where you see the most complex, resource-intensive nursing care.
Right. Managing something that's already happened.
Exactly. Tertiary care focuses on minimizing the damage caused by an existing disease, preventing complications, and really promoting the highest possible level of health despite the condition.
So examples here would be,
Things like rehabilitation after a stroke, that's classic tertiary care, or managing the daily needs and promoting wellness for a patient who's actively undergoing cancer treatment. The problem has already occurred, and now we're focused on optimizing the outcome and preventing things from getting worse.
got it. So To kind of structure all these prevention efforts, there's a national blueprint we rely on, Healthy People 2030. This isn't just some vague idea, is it? It actually guides professional practice.
Oh, it's much more than a vague concept. It's the national model. It sets these data-driven objectives specifically aimed at improving health and well-being across the entire U.S.
And it coordinates efforts?
Yes, it coordinates efforts across all kinds of medical professionals, nurses, doctors, dietitians, community planners, you name it. There are, I believe, 358 core objectives in the current iteration,
Wow.
all aimed at reducing health disparities and promoting wellness. And remember, wellness itself, the definition is important.
Yeah.
It's an integrated method of functioning oriented toward maximizing potential.
Maximizing potential. That phrase really links nicely to the next big topic, the core driver of modern high-quality care, which is evidence-based practice, or EBP.
EBP, yes.
Yeah.
We actually have to move beyond just relying on intuition or, this is how we've always done it.
Right. We need validated research.
We need validated research. So how does EBP actually translate from this academic concept into a practical action plan? There's a clear 4-step process for solving clinical problems using EBP.
Okay, let's break down those 4 steps.
Step 1. You have to clearly identify the issue. And this needs to be based on an accurate analysis of current nursing knowledge and practice. You essentially formulate a PICO question, patient, intervention, comparison, outcome.
Okay, define the problem clearly first.
Then, step 2. You search the literature. You look for relevant peer-reviewed research that addresses your specific question.
Find the evidence.
Step 3, and this is really critical, you evaluate that research evidence. You have to use established criteria to judge its validity, its reliability, its applicability to your patient population. You can't just grab the first article you find.
You have to be critical of the evidence itself. Makes sense.
Exactly. And then the 4th step is where the change happens.
The action step.
Correct. Step 4 is to choose the intervention based on the best evidence you found, and you need to be able to justify that selection with the most valid evidence available. EBP ensures our actions are backed by science, which ultimately maximizes patient safety and effectiveness.
Okay, so we've got the foundation. Now let's dive into the core engine of nursing practice, that systematic framework that structures basically everything we do, the nursing process. And we're specifically emphasizing the 6 steps today using the mnemonic ADPI.
Right, ADPI is common, but that extra I for outcome identification is often tested, and it's clinically important. So ADPI.
Got it.
The nursing process is, yes, a systematic, step-by-step roadmap for patient care. But, and this is crucial, you have to remember it's also really interactive and cyclical. It's definitely nonlinear.
What do you mean by nonlinear?
Well, take the first step, assess. Assessment isn't something you just do once at the beginning and then check off. You are always assessing, constantly gathering new data, even while you're implementing interventions or evaluating outcomes. It's continuous.
Okay, that makes sense. So let's walk through the 6 ADPI steps and really pinpoint the critical thinking that happens in each one.
Okay, sounds good. 1, assess. Like I said, this is the absolute starting point. It's where we compile complete, accurate health data that includes both subjective, what the patient tells us, and objective, what we observe and measure. Everything else, especially the diagnosis, hinges on the quality of this initial assessment. Garbage in, garbage out, right?
Right, foundation.
Diagnose. This is where the analysis happens. We take all that data we gathered and we cluster it. We look for patterns to determine the patient's condition, specifically their human response, using the standardized NANDA-I framework, the North American Nursing Diagnosis Association International.
Okay, clustering data to find the nursing diagnosis.
3, identify goals, outcome identification. This step, the extra I, is where we make sure our plan is directed. We formulate goals that are measurable, realistic, and patient-centered. And importantly, patient outcomes are more specific than the broader goals.
Can you give an example of that, goal versus outcome?
Sure. A broad goal might be, the patient will achieve optimal respiratory function. That's good, but it's vague. A specific, measurable outcome tied to that goal could be, the patient will maintain SpO2 greater than 95% on room air within the next 48 hours. See the difference? Measurable, timed.
Much clearer. Got it.
4, plan care. Now we actually write the formal plan of care.
Yeah.
We figure out what resources are needed. We target specific nursing interventions designed to achieve those measurable outcomes we just set.
So the how-to guide for this patient.
Exactly.
Yeah.
5, implement. This is the action phase. We perform the treatments and interventions outlined in the plan. This also involves things like monitoring their health status continuously and assisting with activities of daily living, ADLs, and again, you're still assessing during implementation, observing their response.
Right, always assess.
6, evaluate. The final step, but like assessment, it's ongoing. Here we judge the effectiveness of our care plan. We look at the patient's response and compare it to those specific outcome criteria we set back in step 3. Did our interventions actually work? Did the patient meet the outcome? Do we need to modify the plan?
Okay. ADITE. Assess, diagnose, identify outcomes, plan, implement, evaluate. But let's pause right there on diagnosis because we absolutely have to hammer home the most critical distinction probably in this whole deep dive. Nursing diagnosis versus medical diagnosis.
Yes, this is fundamental. It's where so many new students get tripped up, and it's tested constantly, not just for definition, but for application.
It's like the litmus test for professional nursing judgment, isn't it?
It really is. The absolute bottom line you must remember, nurses do not make medical diagnoses. That's the physician's or advanced practice provider's role.
Okay, so what is a medical diagnosis then?
A medical diagnosis identifies the disease state. It names the underlying pathology or problem. Think congestive heart failure, pneumonia, or type 2 diabetes mellitus. That's the medical label for the disease.
So sticking with that example, if the medical diagnosis is congestive heart failure, why can't the nurse just rate congestive heart failure on the nursing care plan? Where does our legal and professional responsibility really focus?
Our responsibility, our scope, centers entirely on the patient's experience of that disease and their human responses to it. So if the patient has that medical diagnosis of congestive heart failure, the medical problem is the failing heart pump.
Right.
But the nursing diagnosis addresses the consequences of that failing pump that the patient is experiencing. Things like fluid volume excess because they're retaining fluid, or ineffective breathing pattern because the fluid is backing up into their lungs, or maybe activity intolerance because they get short of breath easily.
Okay, so we're treating the response to the heart failure, not the heart failure itself.
Precisely. Or take pneumonia. Medical diagnosis.
Yeah.
Pneumonia. The nursing diagnosis might be ineffective airway clearance because of all the sputum, or impaired gas exchange if their oxygen levels are low. We treat the patient's response.
That clarity is so helpful. It really cements the application for exams. Okay, so this whole AD-PIPE process, it's fueled by critical thinking. How do we define that?
Critical thinking in nursing is defined as purposeful, outcome-directed thinking. It's driven by patient needs, it's based on evidence-based practice, and it absolutely requires knowledge, skills, and clinical experience. It's not just thinking, it's thinking with a purpose related to patient care.
And how does that kind of abstract idea of critical thinking become concrete when we're actually trying to figure out a nursing diagnosis? What's diagnostic reasoning?
Diagnostic reasoning is the structured, systematic process we use, particularly during the assessment and diagnosis phases of AD-PI. It's like the engine driving critical thinking for diagnosis. It involves about 7 steps.
Okay, let's walk through them.
First, you identify abnormal data and also patient strengths. Don't forget strength. Second, you cluster the data. This is so important. You have to group together the signs and symptoms that logically belong together based on your knowledge.
That sounds like where mistakes can happen, clustering unrelated things.
Huge potential for error there. For example, back pain and nausea in a patient who just got a blood transfusion. That cluster screams possible transfusion reaction. But back pain in a patient who also has a runny nose and cough, probably unrelated, likely musculoskeletal pain plus a common cold. Careful clustering is key.
Needs that deep understanding of pathophysiology.
Exactly. So after careful clustering, step 3 is you draw inferences. What might these clusters mean? Step 4, you propose possible nursing diagnoses. Step 5, you check for the presence of defining characteristics for those diagnoses. Do the patient's signs and symptoms actually match the official NANDA-I definition?
Verifying against the standard.
Yep. Step 6, you confirm or rule out the nursing diagnosis based on all the evidence. And finally, step 7, you document your conclusions, your final nursing diagnoses.
Okay, that makes sense. Now, when we're doing that initial assessment, collecting all that data, we use different frameworks to organize it. You mentioned head-to-toe, functional, and body systems. Which one is specifically cited as the one that really promotes critical thinking by clustering related data, even if it's not always the most physically organized way to do an exam?
That would be the body systems approach. While the head-to-toe approach is generally the most organized and efficient way to perform a comprehensive physical examination, ensuring you don't miss anything.
Right, it's systematic physically.
The body systems approach, where you assess, say, the entire cardiovascular system, then the entire pulmonary system, then GI, and so on, that structure actually promotes critical thinking. It forces you to group data related by pathophysiology, prompting you to analyze the connections between those systems.
Ah, I see. So it encourages thinking about how, say, the heart problem affects the lungs or kidneys.
Exactly. The functional framework, just for completeness, looks at patterns all humans share, like Gordon's functional health patterns, things like mobility, nutrition, sleep, coping. It's another way to organize data, but body systems is the one highlighted for promoting that analytical, critical thinking link. Hashtag tag IVA, prioritization, safety, and teamwork.
Okay, let's shift gears now into the really high-stakes world of prioritization and patient safety. In any clinical situation, especially one designed for an exam to test your judgment, what is the absolute fundamental, non-negotiable rule for setting priorities?
It's simple, but you can never forget it. A life-threatening situation is always the top priority, period. Prioritization isn't random. It requires using your clinical experience, your knowledge base, your expertise, and sound judgment.
And for those immersion unstable situations, we have a classic mnemonic, ABCD.
Yes, ABCDE. It's the go-to framework for rapid assessment in emergencies. Airway, breathing, circulation, disability, exposure.
Okay, let's apply it. Put it into action with a quick scenario. Say you walk into a patient's room, and they suddenly slump over in the chair and start making this high-pitched crowing sound when they try to breathe stridor. What's the immediate critical thinking path triggered by just hearing that sound?
Okay. Stridor is an immediate red flag. That sound instantly signals an acute airway problem. That takes precedence over absolutely everything else.
Before even checking breathing rate.
Before anything else, you have to secure the airway first. If there's any chance of trauma, you must include cervical spine protection simultaneously. Only once the airway is addressed can you move to chest. Breathing, assess their respiratory rate, depth, look for accessory muscle use.
Okay, airway first, then breathing.
Then circulation, check their pulse rate and rhythm, skin color, temperature, capillary refill. Then disability, assess their level of consciousness, LOC, check their pupils, can they move? And finally, exposure, you often need to fully remove clothing to properly assess for any hidden injuries, bleeding, rashes, etc. ABCDE. In that order.
Crucial order. Now, related to this is knowing when to call for help, specifically when to activate the Rapid Response Team, or RRT. This is a huge indicator of clinical judgment on exams. We absolutely must know the specific vital sign limits that signal a patient is crashing or about to. What are those critical triggers?
These numbers need to be practically tattooed on your brain because they indicate serious physiological distress, often before a full code situation develops. You call the RRT for respirations. If they drop below 10 breaths per minute or go above 32 breaths per minute, a rate of 8 means they're tiring out and failing. A rate of 35 means they're working way too hard and will also tire out. Both are critical.
Okay, 10 of 32 for respiratory rate?
Oxygen saturation. If it drops below 92%, some facilities might use 90%, but 92% is a common safe threshold.
SpO2, 92%. Got it.
Pulse. If it falls below 55 beats per minute or jumps above 120 beats per minute, too slow or too fast can compromise cardiac output.
Pulse 55 or 120.
Systolic blood pressure. If it drops below 100 millimeter Hg or rises above 170 millimeters Hg, both extremes signal potential problems, shock, or hypertensive crisis.
SBP 100 or 170?
Temperature. If it's below 35 degrees Celsius or above 39.5 degrees Celsius, that's less than 95 Fahrenheit or greater than 103.1 Fahrenheit. Severe hypo or hyperthermia.
Temp 35 degrees or 39.5 degrees C.
It is not just the numbers. You also call for any acute change in mental status, confusion, lethargy, definitely for stridor, like in your scenario, increasing work of breathing, using accessory muscles, new onset chest pain, or sudden agitation or restlessness. Sometimes that's an early sign of hypoxia.
Those soft signs are critical too. Okay, so that's for a single patient crisis. What if we zoom out to a mass casualty incident or a disaster situation? The whole prioritization game changes then, right? Explain the 4 levels of casualty triage.
Yeah. Disaster triage operates under a different principle. Do the greatest good for the greatest number of people with the limited resources available. So the priorities shift. Priority 1, red tag. These are patients with serious life-threatening injuries, but, and this is key, they are considered salvageable with immediate intervention. Think major hemorrhage you can control or a tension pneumothorax you can decompress. Immediate need, good chance of survival if treated now.
Okay, life-threatening but salvageable, red.
Priority 2, yellow tag. These patients have moderate to serious injuries, but they are not immediately life-threatening. They can likely wait a few hours for definitive treatment without dying. Think major fractures, large wounds without massive bleeding.
Serious, but can wait a bit. Yellow.
Priority 3, green tag. These are the walking wounded. Minor injuries, cuts, abrasions, minor fractures. They need care eventually, but they can wait the longest.
Minor injuries. Green.
Non-priority, blue or black tag. Unfortunately, these are patients with catastrophic injuries who are not expected to survive, given the circumstances and limited resources. Or they may already be deceased. Trying to treat them would divert critical resources from salvageable patients. It's a harsh reality of disaster medicine.
Right. A very different calculation.
Yeah.
Okay, bringing it back to everyday hospital practice. Let's talk basic safety. Infection control.
Right.
We know standard precautions, gloves, maybe gown, mask, eye protection, depending on the task, are used with every single patient, right? Regardless of diagnosis.
Every patient, every time. Treat everyone as potentially infectious. That's the core of standard precautions.
But what's the single most important strategy for preventing the transmission of infection? The one thing that trumps everything else.
It is, without a single doubt, hand hygiene. Washing your hands with soap and water or using alcohol-based hand rub. It is the absolute cornerstone of infection prevention. Nothing is more effective.
Got it. Hand hygiene above all. And when we do need personal protective equipment, PPE, what factors guide our selection?
You need to think about 3 things. First, the type of anticipated exposure are you likely to encounter: touch, splashes or sprays, or airborne particles. That dictates gloves, gown, mask, face shield. Second, the durability of the PPE needed for the specific task. And third, ensuring a proper fit, especially for things like N95 respirators.
Makes sense. Now, another huge safety component relies on effective interprofessional communication. The statistics are pretty sobering here. Something like 75% of sentinel events, those serious unexpected adverse outcomes, have communication failures as a root
This
cause.
is a terrifying statistic, and it highlights why standardized communication is so vital. Poor communication literally costs lives.
So how do we standardize that critical communication, especially when reporting a change in patient condition to a physician or another provider?
The gold standard, the framework we rely on, is the SBR model. It provides an organized, predictable structure for sharing critical information.
Okay, let's break down SBR.
S stands for situation. What is happening right now? What's the immediate problem? Be concise. Mr. Jones in room 204 is having sudden onset chest pain.
Clear and direct, S.
B is for background. What is the relevant context? Patient's diagnosis, pertinent history, recent vital signs, relevant meds. He's a 65-year-old male admitted yesterday for observation after a fall, history of hypertension.
Relevant context, B.
A is for assessment. What are your clinical findings? What do you think is going on? His vital signs are BP 16095, pulse 110, RR24, SpO2 92% on room air. He rates his pain 810, radiating to his left arm. Lung sounds are clear. This is your professional
So
assessment.
your findings and analysis, A.
And R is for recommendation. What do you need? What action do you think should be taken? I recommend you come see the patient immediately. Should I get an EKG and start oxygen?
What you need done are, so SBR, situation, background, assessment, recommendation, and ensures nothing critical gets missed in the heat of the moment.
Exactly. It provides structure and clarity, reducing errors. And of course, all of this communication, all of our assessments, all of our interventions, they have to be recorded accurately through documentation.
Ah, documentation. Not always the most glamorous part of nursing, but absolutely essential.
Essential and legal. It cannot be overstated. The old saying is completely true. If it wasn't documented, it wasn't done. Your charting is the official legal record of the care provided. It protects the patient, protects you, and ensures continuity of care.
And hovering over all documentation is the specter of HIPO.
Right. The Health Insurance Portability and Accountability Act. HIPAA mandates that we keep patient health information private and secure. And a critical component often tested is the principle of minimum necessary. We should only access, use, or disclose the absolute minimum amount of protected health information needed to accomplish the intended purpose, usually providing care.
Okay, minimum necessary. And in terms of charting formats, we often see things like SOPP notes or DR notes mentioned.
Yes, those are common formats. SOP stands for subjective data, objective data, assessment, which here often means the nursing diagnosis or impression, and plan. DR stands for data, which includes both subjective and objective, action, the nursing intervention, and response, patient's response to that action.
Hmm.
Different facilities use different formats, but they all aim to organize the key information.
Okay, let's circle back quickly to data types because it's so fundamental. We talked about subjective and objective. Let's use that curtain trick analogy again to make it crystal clear for exams. How do we definitively separate subjective data from objective data?
Okay, imagine the patient is physically behind a curtain, and you can only talk to them. Anything you can gather just by talking with them through the curtain, that's subjective data.
Like what?
Their pain level. My pain is a 7 out of 10.
Mm.
Their feelings, I feel nauseous. Their health history, I have a history of asthma. Their chief complaint, I came in because of shortness of breath. It's what the patient or sometimes a caregiver tells you. It's their perspective. They are the primary source, and you usually gather it through therapeutic dialogue.
Okay, information from the patient. Subjective. So objective data is...
Objective data requires the curtain to be open. It's anything you, the nurse, can observe, measure, see, hear, smell, or feel directly.
things you gather yourself.
Exactly. Measurable, observable information, vital signs, BP, pulse, temp, RRs, PO2, auscultated sounds, listening to lungs or heart, visual appearance, skin color, presence of edema, wound condition, laboratory values, the results of your physical assessment maneuvers like palpation or percussion. It's the data you collect directly through your senses or measurement devices. #tag VEET detailed clinical assessment application.
All right, we've built the foundation, tuned up the reasoning engine, and checked the safety systems. Now it's time to apply all this knowledge to the actual hands-on part of care. Starting with those fundamental techniques we use in a physical assessment, #tag VA assessment techniques and vital signs.
Okay, the 4 fundamental techniques. Easy to remember with the mnemonic IPPA: inspection, palpation, percussion, auscultation.
And the first one, inspection, you said earlier it's the most continuous.
Absolutely. Inspection isn't just a quick look. It's the conscious, deliberate act of observing the patient. You're looking at their general appearance, their hygiene, their posture, their gait, their behavior, facial expressions, any equipment they're using. It starts the instant you encounter the patient and
Yeah.
literally continues throughout your entire interaction, your whole shift.
And it's the only technique used for every single body part and system, right?
That's correct. You inspect everything.
Okay, I for inspection. Next is P, palpation. This is the clinical touching part. What are we feeling for, and are there specific ways we use our hands?
Palpation is using touch to assess various characteristics. Texture, smooth, rough. Temperature, warm, cool. Moisture, dry, diaphoretic. Size of organs or masses. Consistency, soft, firm, hard. Swelling, vibration or pulsation. Rigidity, crepitation, presence of lumps or masses, and crucially, tenderness or pain.
Lots of information through touch.
A ton. And how you use your hands matters. The finger pods are best for fine tactile discrimination, things like assessing skin texture, swelling, pulsation, and finding lumps. The dorsal surface, the back of your hand and fingers, is most sensitive to temperature.
Back of the hand for temp. Good tip.
Always remember to start with light palpation first, about 1 centimeter deep. This allows the patient to get used to your touch and helps you detect surface characteristics and tenderness. Then you can proceed to moderate or deep palpation, 1 to 2 centimeters or more, if needed, and only if appropriate and you're trained for it. And always ask permission before touching, especially in sensitive areas or if cultural norms dictate.
Light before deep. Got it. Okay, the second P is percussion. This involves tapping. What's the goal here? What are we listening for?
Percussion is tapping the patient's skin with short, sharp strokes to create vibrations and resulting sounds. These sounds help determine the location, size, and, most importantly, the density of the underlying organs or tissues.
Density determines the sound.
Exactly. The basic principle is the more dense the underlying structure, the quieter the tone. Solid tissue like bone or muscle produces a very quiet, flat, or dull sound. Structures filled with air or fluid, like the lungs or the abdomen, produce much louder tones because they vibrate more freely.
Okay, so what are the normal sounds we expect to hear?
Over normal air-filled lung tissue, the expected sound is resonant. It's described as a clear, hollow, medium-loud sound. Over the abdomen, particularly over the stomach and intestines, which contain air and fluid, the normal sound is tympanic. Think of like a drum. It's loud, high-pitched, musical, or drum-like. Abnormal sounds like dullness over the lungs could indicate fluid or a solid mass like pneumonia or a tumor.
Resonance in lungs, tympany in abdomen, key normals. All right, the final A in IPPA is auscultation, listening.
Auscultation is listening to sounds produced by the body, usually using a stethoscope. We listen to heart sounds, breath sounds, bowel sounds, and sometimes vascular sounds like bruits.
And the stethoscope itself, crucial reminder.
Remember, the stethoscope conducts sound. It does not amplify it. So a quiet room is essential. You need good contact with the skin.
Right. And the two sides of the chest piece, the diaphragm and the bell.
The large, flat side is the diaphragm. It's best for hearing high-pitched sounds. Think normal breath sounds, normal heart sounds, S1, S2, and bowel sounds. You need to press it firmly against the skin.
Diaphragm for high-pitched, press firmly.
The smaller, cup-shaped side is the bell. It's best for hearing low-pitched sounds. Think abnormal heart sounds like murmurs, S3, S4, or certain vascular sounds like brutes. You need to place the bell lightly on the skin, just enough to create a seal. Pressing too hard stretches the skin and makes it act like a diaphragm, filtering out the low sounds you're trying to hear.
Bell for low-pitched, press lightly. Got it.
Okay.
Okay, these techniques, IPPA, allow us to gather data, including the baseline indicators of health status, the vital signs. We mentioned the RRT triggers earlier, but let's quickly recap the key normal adult ranges that are absolutely non-negotiable to know for exams.
Okay, the core normals you got to know. Temperature. Generally 36.5 to 37 degrees Celsius, which is about 97.7 to 98.6 degrees Fahrenheit. But remember, route matters. Rectal temps are usually a bit higher than oral, axillary a bit lower.
Temp, 36.5, 37C, 97.7, 98.6F.
Pulse. Normal resting heart rate for an adult is 60 to 100 beats per minute. Rhythm should be regular.
Pulse, 60, 100 BPM.
Respirations, 12 to 20 breaths per minute for an adult at rest. Should be regular and unlabored.
Respirations, 12, 20 breaths min.
SpO2, oxygen saturation. Normal is typically 92% to 99% on room air. Some sources might say 95, 100%, but below 92% is generally concerning. Remember, less than 85% is an emergency signaling inadequate oxygenation. And be a little cautious about 100% in some specific situations, like a patient on high-flow oxygen that could indicate hyperoxemia, too much oxygen.
SpO2, 92, 99%. Critical below 85%.
Blood pressure, BP. Systolic pressure, ideally between 90 and 120 millimeter Hg. Diastolic pressure, ideally between 60 and 80 millimeter Hg. Remember, these are ranges, and trends are important.
BP, systolic 90, 120, diastolic 60, 80.
Those are the key ones to have down cold.
Definitely.
Yeah.
And just a quick practical note for difficult situations. The Doppler technique for BP. When and why would we use that, and how is it recorded?
You'd use a Doppler ultrasonic device when you can't palpate a peripheral pulse, often in patients with very low blood pressure, like in shock, or those with severe peripheral vascular disease, or maybe even obese patients where feeling the pulse is hard.
Okay, can't feel the pulse.
The Doppler transducer is placed over the artery, and it picks up the sound of blood flow. You inflate the cuff as usual, then slowly deflate it. The point where you first hear the whooshing sound return is the systolic blood pressure. Crucially, the Doppler technique usually only measures the systolic BP accurately.
Only systolic. How do you chart that?
You must record it clearly, indicating the Doppler was used. For example, if you heard the sound return at 88 millimeter Hg, you would chart it as 88 Doppler. You don't estimate the diastolic. Hashtag VB pain assessment, the fifth vital sign.
Okay, moving on to what's often called the fifth vital sign, pain. This one is tricky because it's entirely subjective. What's the absolute fundamental patient-centered principle we have to internalize for pain assessment?
It's simple, powerful, and non-negotiable. Pain is whatever the experiencing person says it is, existing whenever they say it does. You absolutely must adopt this philosophy. It acknowledges that pain is a complex personal experience that profoundly impacts quality of life, family interactions, everything. Your personal opinion or observation of their behavior doesn't override their report.
Believe the patient. Got it. Let's touch briefly on the science behind it. What's nociception, and how does the gate control theory help us understand why things like rubbing an injury sometimes help?
Okay, nociception is the term for the physiological process, the most common way we understand how pain signals travel. It involves four main steps. 1. Transduction. The initial injury or stimulus activates nerve endings, nociceptors, converting that stimulus into an electrical signal. 2. Transmission. That electrical signal travels along nerve fibers up the spinal cord to the brain. 3. Perception. The brain receives and interprets the signal as pain. This is where it becomes a conscious experience. 4. Modulation. The brain and spinal cord can release substances, like endorphins, that inhibit or modify the pain signal, dampening the perception. Okay, the 4 steps of the signal pathway. Right. Now, the gate control theory, proposed by Melzack and Wall, is a bit different. It suggests there's a kind of neurological gate mechanism in the spinal cord's dorsal horn. This gate can either open to allow pain signals from peripheral nerves, specifically small A delta and C fibers, to travel up to the brain, resulting in the perception of pain.
Open gate equals pain felt.
Or the gate can be closed by activating larger nerve fibers, A beta fibers, which carry signals for touch, pressure, vibration. When these larger fibers are stimulated, say, by rubbing the injured area, applying heat or cold or TENS units, they can essentially close the gate, blocking the pain signals from the smaller fibers from reaching the brain.
Ah, so stimulating other nerves blocks the pain signal. That makes sense why distraction or rubbing helps.
Exactly. It explains the mechanism behind many non-pharmacological pain interventions. It's about modulating the signal transmission. It also involves descending pathways from the brain that can influence the gate. Oh, and speaking of fibers, remember the difference. A-delta fibers transmit sharp, stabbing, localized pain quickly. C fibers transmit dull, aching, burning, more diffuse pain slowly.
A delta, fast sharp. C fibers equals slow edge. Good distinction. Okay, we have different types of pain. We know about acute, sudden, usually from tissue damage, and chronic, lasting longer than 3-6 months, affecting about 10% of U.S. adults daily. What about neuropathic pain? What makes it different?
Neuropathic pain is distinct because it originates from damage or dysfunction within the nervous system itself, the nerves, spinal cord, or brain, rather than from stimulating healthy pain receptors in tissues.
So it's the wiring itself that's damaged?
Pretty much. This damage can lead to abnormal processing of pain signals. It often results in a more constant, spontaneous pain stimulus and can lead to changes in the nerves called neuronal plasticity and peripheral sensitization, making them hypersensitive. It often feels different, too. Patients describe it as burning, tingling, shooting, stabbing, electrical shocks. And importantly, it's often resistant to traditional opioid analgesics. Requires different types of treatment, like certain antidepressants or anticonvulsants.
Okay, different cause, different feel, different treatment. Good to know. What about other types like visceral, somatic, referred?
Quick rundown. Visceral pain originates from internal organs, like abdominal cramping or angina from the heart. It's often diffuse, poorly localized, can be deep, squeezing, cramping. Somatic pain comes from musculoskeletal tissues or the body surface bone, joint, muscle, skin, connective tissue. It's usually more localized and can be sharp or dull, like a sprained ankle or arthritis. Cutaneous is a subtype of somatic, just from the skin surface, like a paper cut. Referred pain is felt in a location different from the actual site of injury or pathology. Classic example is left arm pain during a heart attack or shoulder pain from gallbladder problems. And phantom pain is felt in a body part that's been amputated.
Lots of categories.
Yeah.
Okay, critical thinking time. When does pain become an urgent assessment, something requiring immediate action?
Any pain that signals immediate physiological danger or potential tissue damage must be prioritized. The classic examples are new onset chest pain. You must treat this as a potential myocardial infarction, MI, until proven otherwise. Requires immediate EKG, assessment, intervention. Another big one is the patient reporting the worst headache of my life, especially if sudden onset. This could indicate a subarachnoid hemorrhage, brain bleed, and is a neurological emergency.
Chest pain and worst headache, immediate action.
Also, severe, uncontrolled acute pain itself can cause physiological stress, leading to high blood pressure, tachycardia, fast heart rate, sweating, diaphoresis, increased respiratory rate. While maybe not immediately life-threatening like an MI, these signs indicate significant distress and require prompt intervention. Chronic pain usually doesn't produce these acute physiological changes because the body adapts.
Right, the body adapts to chronic pain signs. Okay, when we're collecting the subjective data about pain, we use structured mnemonics to make sure we cover all the bases. What are the common ones?
Two popular ones are OPQRST and OLD CARTS. They cover similar ground. OPQRST, onset, when it starts. Provocative, palliative, what makes it worse, what makes it better. Quality, what does it feel like? Sharp, dull, dull, burning. Region radiation, where is it spread anywhere? Severity, pain scale rating 0 to 10. Timing, is it constant, intermittent, how long does it last?
Right.
OLD CARTS, onset, location, duration, character, quality, aggravating, alleviating factors, radiation, timing, severity.
Using one of those helps ensure a comprehensive pain history. Now, how do we actually measure the intensity, especially for exams? What are the key pain assessment tools we need to know, particularly for different populations?
Okay, tools are key. One-dimensional scales, these just measure intensity. The most common by far is the Numeric Pain Intensity Scale, NPI or NRS, asking the patient to rate their pain on a scale of 0 to 10, where 0 is no pain and 10 is the worst imaginable pain. Simple, widely used for adults who are alert and oriented. There's also the Visual Analog Scale, VAS, which is a 10-centimeter line the patient marks.
0-10 scale is standard for adults.
Multidimensional scales. These capture more than just intensity. The Brief Pain Inventory, BPI, assesses intensity, but also how pain interferes with daily activities. The McGill Pain Questionnaire, MPQ, is more detailed, looking at sensory, affective, and evaluative aspects of pain using word descriptors. A newer one is a clinically aligned pain assessment, CAPA, tool, which looks at 5 elements: comfort, changes in pain, pain control, functioning, and sleep.
Okay, those are more comprehensive. What about
For
kids?
children, the scale depends on age and developmental level. The Faces Pain Scale Revised, FESR, the one with the 6 cartoon faces showing different expressions from smiling to crying, is typically used for children aged 3 years and older. They can point to the face that shows how they feel, or pick a number associated with the face.
A face is for ages 3 plus.
For infants and younger children who can't self-report, typically from 2 months up to 7 years old, or for nonverbal older children and adults, we use the FLACC scale. FLABC is an acronym for observing face, legs, activity, cry, and consolability. Each category gets a score of 0, 1, or 2 for a total score out of 10. It's an observational behavioral scale.
FLACC for infants nonverbal, 2 months, 7 years. Face, legs, activity, cry, consolability.
Excellent. Finally, on pain, we have to talk about barriers and potential bias. What if a patient says they're in severe pain, but they're lying quietly in bed, maybe even watching TV?
This is where that foundational principle comes back. Pain is what the patient says it is. You must assess and document the pain score as reported by the patient, regardless of their body language or behavior. People cope with pain differently. Some are stoic, some may use distraction like TV. Their behavior doesn't invalidate their report.
Okay, report trumps behavior. What about bias related to substance use? This is a huge area for potential bias and a critical point for patient safety and exams. Nurses must be acutely aware of any personal biases, especially concerning patients who are opioid tolerant due to chronic pain management, or patients who have a history of substance use disorder. These patients are absolutely entitled to adequate pain assessment and relief, just like any other patient. Provider bias or fear of contributing to addiction cannot interfere with our obligation to treat their pain effectively and compassionately. They may require higher doses due to tolerance, and that needs to be managed appropriately, not judged. #VC Cultural and Social Assessment.
All right, let's broaden the lens beyond the physical. Understanding a patient truly means understanding their context, starting with culture. Now, before we even begin asking a patient about their cultural beliefs, what is the absolutely crucial first step the nurse must take?
This is fundamental, the bedrock of culturally competent care. The nurse must first engage in self-reflection and self-awareness. You absolutely have to define and become aware of your own cultural background, your own values, beliefs, biases, and prejudices.
Why is that so critical as the first step?
Because if you're not aware of your own cultural lens, your own assumptions, they will inevitably, unconsciously interfere with your ability to provide objective, non-judgmental, patient-centered care. You might impose your own values or misunderstand the patient's perspective. Self-awareness is the foundation upon which genuine cultural competency is built.
Okay, self-awareness first. So, how do we define cultural competency itself? It's more than just knowing facts about different cultures, right?
Much more. Cultural competency is defined as a dynamic, ongoing process, not a one-time achievement. It's the process of acquiring the ability to provide care that is effective, safe, and of high quality by meeting the complex social, cultural, and linguistic needs of diverse patients, families, and communities.
And the benefits are significant.
Huge. When we practice cultural competency, we can directly reduce healthcare disparities, improve patient safety and adherence, enhance communication, and most importantly, build that essential element of patient trust.
Okay, so when we do conduct a cultural assessment with a patient, what are the main goals? What are we trying to achieve beyond just gathering information?
The aims are multifaceted. Yes, we want to gain knowledge about the patient's specific values, beliefs, and practices related to health and illness. But we also need to compare those specific needs with general themes or patterns within their cultural group, while avoiding stereotypes. We need to identify similarities and differences between our perspective and the patient's. And ultimately, the goal is to use all this information to generate a holistic picture of the patient, allowing us to create a mutually agreeable and effective care plan.
Because a plan won't work if it clashes with their core beliefs.
Exactly. Patients are far less likely to accept or comply with a treatment plan if it's inconsistent with their deeply held cultural practices or beliefs. This is especially true in areas like food and nutrition. Think about religious fasting periods like Ramadan, kosher, or halal dietary laws. Beliefs about hot and cold foods in some cultures. Pregnancy and childbirth. Many cultures have specific rituals, preferred support persons, or postpartum practices. Beliefs about pain. How pain should be expressed or endured varies dramatically. Some cultures value stoicism, others encourage open expression, death and grieving. Beliefs about end-of-life care, autopsy, burial, or cremation practices, and mourning rituals are highly culturally specific.
Think about Jehovah's Witnesses refusing blood products, or certain Hindu or Muslim practices regarding handling the body after death, or preferences for same-gender caregivers. Ignoring these can cause significant distress and distrust.
Really important considerations. Now, shifting slightly from individual culture to the broader environment, we have the concept of social determinants of health, or SDOH. These are the conditions and the places where people live, learn, work, and play that affect health risks and outcomes. Healthy People 2030 really emphasizes these, right?
Absolutely. SDOH are a major focus because we now understand that social and economic factors contribute significantly, often more than medical care itself, to health disparities and overall health outcomes. Healthy People 2030 groups them into 5 key domains.
What are those 5 domains?
1. Economic stability. This includes things like poverty, employment status, food security, housing stability. 2. Education access and quality. Literacy levels, early childhood education, high school graduation rates, enrollment in higher education. 3. Healthcare access and quality. Health insurance coverage, availability of providers, linguistic and cultural competency of care. 4. Neighborhood and built environment. Quality of housing, access to transportation, availability of healthy foods, food deserts, crime and violence levels, environmental pollution. 5. Social and community context. Social support systems, civic participation, experiences with discrimination or racism, incarceration rates.
Wow, those cover a huge range of factors that clearly impact health.
They really do. Understanding these social determinants is crucial for addressing health inequities at a population level.
And when we're assessing a community, perhaps for a public health perspective, we sometimes talk about building blocks. Can you explain those categories? How do we group community assets?
Right, this is often used in community assessment models. The idea is to identify the resources and assets within a community. They're typically grouped into 3 categories. Primary building blocks. These are the assets and capacities located inside the community and largely controlled by people within the community. Think local resident skills, individual businesses, homeowner associations, cultural organizations, local schools, libraries, parks, police, and fire departments. These are the most accessible assets.
Okay, internal and locally controlled. Primary.
Secondary building blocks. These are assets still located within the community, but largely controlled by people or entities outside the community. Think of social service agencies that have branches in the area, but are part of a larger corporation or government entity. Hospitals, larger corporations, local branches. They serve the community, but decisions might be made elsewhere.
Inside the community, but controlled from outside. Secondary.
Potential building blocks. These are resources originating outside the community, controlled by outsiders, that could potentially be drawn upon or redirected to benefit the community. Think of welfare expenditures, public information, support from regional or national foundations, politicians, large corporations headquartered elsewhere. These are the least accessible, requiring more effort to tap into.
Outside resources that could help. Potential.
No.
Got it. Hashtag tag VD developmental stages across the lifespan. Okay, let's pivot to another critical dimension of the patient, their developmental stage. Understanding where someone is developmentally is key to tailoring communication and care. Erickson's model of psychosocial development is a big one, often tested on the NCLEX for application. Let's quickly review those stages and their core conflicts.
Erickson stages are definitely high yield. They describe the psychosocial challenges or crises we face at different points in life. Successfully navigating each crisis builds psychological strength for the next stage. Infant, birth to 1 year. Trust versus mistrust. The core question is, can I trust the world and the people providing my care? Consistent, loving care builds trust.
Trust versus mistrust for infants.
Toddler, 1 to 3 years, stage 2. Autonomy versus shame and doubt. This is the me-do-it stage. They're learning to exercise their will, make choices, and control themselves, like toilet training. Success leads to autonomy. Repeated failure or criticism leads to shame and doubt. Erickson famously described this as learning to hold on and let go.
Autonomy versus shamed out for toddlers. Holding on, letting go.
Preschooler, 3 to 6 years, stage 3. Initiative versus guilt. Kids at this stage are exploring, asserting power and control over their environment, initiating activities. If encouraged, they develop initiative. If made to feel anxious or irresponsible, they develop guilt. Am I good or bad?
Initiative versus guilt for preschoolers.
School age, 6 to 12 years, stage 4. Industry versus inferiority. The focus shifts to mastering social and academic skills. Competence leads to feelings of industry. Difficulty leads to feelings of inferiority. Can I make it in the world of people and things?
Industry versus inferiority for school age.
Adolescent, 12 to 18 years, stage V. Identity versus role confusion. This is the big one for teens figuring out who they are. developing a sense of self and personal identity. Success means staying true to yourself. Failure leads to confusion about their role in life.
Identity versus role confusion for adolescents.
Early adult, late teens to 40 years, stage 6. Intimacy versus isolation. The focus is on forming intimate, loving relationships with other people. Success leads to strong relationships. Failure results in loneliness and isolation.
Intimacy versus isolation for early adults.
Middle adult, 40 to 65 years, stage 7. Generativity versus stagnation. Adults need to create or nurture things that will outlast them, often by having children or creating positive changes that benefit others. Success leads to feelings of usefulness and accomplishment. Generativity. Failure results in shallow involvement in the world. Stagnation.
Generativity versus stagnation for middle adults.
Late adult, 65 years to death, stage 8. Ego integrity versus despair. This involves looking back on life. Feeling a sense of fulfillment and wisdom leads to integrity. Regret, bitterness, and dissatisfaction lead to despair. Did I live a meaningful life?
Ego integrity versus despair for late adults. Okay, that's Erikson's psychosocial stages. We often pair this with Piaget's theory of cognitive development, right?
Right. Piaget focused on how thinking develops, briefly. Sensorimotor stage, infant, birth to 2 years. Learning through senses and actions. Object permanence develops. Pre-operational stage, the preschooler, 2 to 7 years. Symbolic thinking emerges. Language develops, but thinking is egocentric. Concrete operation stage, school age, 7 to 11 years. Can think logically about concrete events, understand conservation. Formal operation stage, adolescent young adult, 12 plus years. Can think abstractly, reason hypothetically, consider multiple outcomes.
Sensorimotor, pre-operational, concrete, formal.
Got it.
Yeah.
Okay, let's zoom back in on infants for a second, focusing on physical development. Those first months and year involve incredibly rapid changes. What are the key weight and length milestones nurses absolutely need to know for assessing adequate growth?
These are classic pediatric assessment points, definitely testable. The two biggest physical growth milestones to remember are, 1, babies should generally double their birth weight by about 6 months of age. 2, they should generally triple their birth weight by 1 year of age.
Double by 6 months, triple by 1 year.
Okay, and for length, they should increase their birth length by about 50% by the end of the first year. These are critical benchmarks for assessing nutritional status and overall growth trajectory in infants. Significant deviations warrant further investigation.
50% increase in length by 1 year. Good benchmarks. Okay, let's jump to the other end of the lifespan. Older adults. What's a crucial mindset shift we need when assessing this population? The most important thing to remember, and to counter societal bias, is that disease is not a normal part of aging. While the risk of chronic illness increases with age, attributing symptoms solely to old age without proper assessment is dangerous and constitutes ageism. We must investigate symptoms thoroughly.
Don't just write it off as aging. How does the assessment approach differ for older adults?
Assessment often requires a spiralized, more patient approach. You may need to allow more time due to potential sensory deficits, mobility issues, or slower processing speed. Do not rush the patient. You also need to be aware that normal physiological changes of aging, like decreased temperature regulation or blunted pain perception, might mask signs of serious illness.
Be patient, be thorough. Are there specific screening tools often used with older adults?
Yes, several are common. For nutritional risk, the Malnutrition Universal Screening Tool, MALIST-A. For functional status, the ability to perform self-care, the CATS Index of Independence and Activities of Daily Living, ADL. For mood, the Geriatric Depression Scale, GDS. These tools help identify common issues in older adults that require further assessment.
AMIST, CATS ADL, Geriatric Depression Scale. Good to know. Okay, critically important point. Where does developmental assessment, like checking milestones or using Erikson's stages, fall in the priority hierarchy when compared to acute physical problems?
This goes back to our ABCs and prioritization rules. An urgent developmental assessment issue, like concerns about cognitive delay or psychosocial adjustment, will always take a backseat to an acute physiological crisis. Emergency situations, significant injuries, suspected overdose, acute chest pain, signs of sepsis always take priority over psychosocial or developmental domains. You stabilize the patient physically first. Maslow's hierarchy applies basic physiological needs, and safety come before psychosocial needs. #, VE mental health, violence, and substance use.
All right, let's transition to the often complex and sensitive area of mental health, violence, and substance use assessment. When assessing a patient presenting with potential mental health issues, what is always the very first thing a nurse must prioritize, even before digging into their chief complaint?
Safety first, always. Before you explore why they came in or what their mood is like, you absolutely must question safety specifically. Risk of harm to self or others. Are they having thoughts of suicide? Do they have a plan? Are they having thoughts of harming someone else?
So suicidal or homicidal ideation assessment comes first.
Immediately. Any indication of suicidal or homicidal thoughts requires urgent, immediate attention, intervention, and appropriate escalation of care according to facility protocol. Safety trumps everything else in a mental health assessment.
Safety first. Got it. Now, related to safety is the assessment for violence and abuse. This carries significant legal responsibility for nurses. What is the nurse's specific legal role here?
Nurses are mandated reporters. This is a legal obligation in all 50 states. If you suspect child abuse or neglect, elder abuse or abuse-neglect of vulnerable adults, those with disabilities that impair their ability to protect themselves, you are legally required to report your suspicions to the appropriate state agency, usually Child Protective Services or Adult Protective Services. Mandated reporter for suspected abuse neglect. Non-negotiable. What about conducting the interview itself, especially if you suspect intimate partner violence or another sensitive issue? What's the rule about privacy when using family members?
Privacy is paramount. Interviews about potential violence or abuse must be conducted in absolute privacy, away from family members, partners, or caregivers. And under no circumstances should you ever allow family members or partners to translate during these sensitive discussions.
Why not? Seems helpful sometimes.
Because the accompanying person may be the perpetrator, or they may coerce the patient or alter the translation to hide the abuse. Using family as interpreters in situations of potential violence severely compromises patient safety and prevents accurate disclosure. You must use a qualified, impartial medical interpreter.
Okay, private interview, professional interpreter only.
Yeah.
What are some general red flags that might suggest underlying violence or abuse? Be alert for things like unexplained injuries, injuries inconsistent with the explanation given, frequent visits for vague complaints, delays in seeking treatment, new onset or significant changes in behavior like withdrawal, depression, anxiety, aggression, signs of fear or anxiety in the presence of a particular person, non-compliance with treatment plans, or reluctance to speak openly. These should trigger further private assessment. We need to be aware of various forms too: family violence, intimate partner, elder, child, sexual violence, human trafficking, hate crimes.
Good red flags to watch for. Okay, let's turn to substance use disorder. Can you clarify the term dependence? What does that specifically indicate?
In the context of substance use, dependence refers to the physiological adaptation of the body to a substance. It's characterized by two key signs: increased tolerance, needing more of the substance to achieve the same effect, and POTR experiencing withdrawal symptoms upon cessation or reduction of use. Dependence can occur with prescribed medications too. It doesn't automatically equal addiction, but it's a component of it.
Tolerance and door withdrawal, dependence. What screening tools are commonly used to assess for potential alcohol use disorder?
The most common screening tools are the CAGE questionnaire and its adapted version, CAGE-AID. CAGE is a quick 4-question screen for alcohol. CAGE is a quick 4-question screen for alcohol. Have you ever felt you should cut down on your drinking? CAGE is a quick 4-question screen for alcohol. Have people annoyed you by criticizing your drinking? CAGE is a quick 4-question screen for alcohol. Have you ever felt bad or guilty about your drinking? CAGE is a quick 4-question screen for alcohol. Have you ever had a drink first thing in the morning, eye-opener, to steady your nerves or get rid of a hangover?
CAGE. Cut down, annoyed, guilty, eye-opener.
Yes. 2 or more yes answers suggest a potential problem requiring further assessment. CAGE-AID adapts these questions to include, adapted to include drugs as well.
Okay. And if someone is experiencing alcohol withdrawal, what tool do we use to monitor the severity of their symptoms and guide treatment?
For monitoring active alcohol withdrawal, the standard tool is the CIWA scale, the Clinical Institute Withdrawal Assessment for Alcohol, revised CIWAR. It systematically assesses and scores various signs and symptoms like nausea, vomiting, tremor, anxiety, agitation, sweats, orientation, headache, and sensory disturbances. The score guides the administration of medications, usually benzodiazepines, to manage withdrawal safely.
CIWA for monitoring withdrawal severity. Good.
Sure.
And in the context of the current opioid crisis, what's the immediate action for overdose? And what's the principle regarding pain relief for patients with a history of use?
Opioid overdose is a medical emergency requiring immediate intervention, primarily with the administration of naloxone, Narcan, an opioid antagonist. Often, multiple doses are needed to reverse respiratory depression. And circling back to our pain discussion, it is absolutely critical to remember and uphold the principle that patients with a history of substance use disorder are still entitled to adequate pain assessment and relief for acute pain, for example, post-surgery trauma. Bias cannot prevent treatment. Pain management might be more complex, requiring multimodal approaches and careful monitoring, but their pain is real and deserves treatment.
Entitled to pain relief. Critical point. Okay, let's clarify the differences between three conditions that can sometimes present similarly, especially in older adults. Delirium, dementia, and depression. This is a very high-yield area for application questions.
Absolutely. Distinguishing the three Ds is crucial because the causes and management are vastly different. Delirium. Think acute and fluctuating. Delirium has a sudden onset, usually hours to days, maybe weeks. Its hallmark is a disturbance in attention, difficulty focusing, easily distractible, and awareness, which fluctuates throughout the day. Thoughts are often disorganized, speech incoherent, perception may be altered, hallucination solutions. Critically, delirium is usually caused by an underlying medical condition, substance intoxication or withdrawal, infection, dehydration, electrolyte imbalance, etc. It represents an emergent situation requiring immediate assessment to find and treat the underlying cause.
Delirium, acute onset, fluctuating attention, medical emergency.
Dementia. Think slow and progressive. Dementia has an insidious, slow onset, developing over months to years. The primary deficit is in cognitive function, particularly impaired memory, especially recent memory first, then remote memory later. Intellect becomes globally impaired over time. While attention may be affected late in the disease, it's generally preserved in the earlier stages, unlike the fluctuating attention of delirium. Consciousness level is typically normal until very late stages. It's usually caused by irreversible neurodegenerative diseases like Alzheimer's.
Dementia, slow onset, primarily memory cognitive decline, attention usually preserved early on.
Depression. Think mood and motivation. Depression also typically has a slower onset than delirium, though sometimes triggered by an event. The core feature is a pervasive low mood, sadness, hopelessness, anhedonia, loss of interest, pleasure. Cognitive symptoms like impaired memory and concentration, pseudodementia, can occur, but they tend to be related to lack of motivation or effort rather than a primary cognitive decline like in dementia. Attention may be impaired due to preoccupation or apathy. And crucially, the risk of suicide significantly increases with depression and must always be assessed.
Depression, slower onset, low mood anhedonia primary, cognitive issues often related to motivation, suicide risk. That's a great breakdown. Okay, so when we do a comprehensive mental health assessment, a common framework used is ABCT. What does that stand for?
ABCT provides a useful structure. A. Appearance. What do you observe about their physical appearance? Hygiene, grooming, dress, appropriate for weather. Posture, gait, any notable physical characteristics. B. Behavior. How are they acting? Level of consciousness, LOC, alert, lethargic, stuporous, facial expression, eye contact, speech, rate, rhythm, volume, articulation, mood, what they say they feel, and affect what you observe their emotional tone to be flat, labile, appropriate. Body movements, agitated, restless, slowed. C. Cognitive function. This is a big one. Assess orientation, person, place, time, situation, attention span, can they focus? Memory, recent or remote. Abstract reasoning and judgment. Are their decisions realistic? This is where you might use screening tools like the Mini-Cog, 3-item recall and clock drawing, or the Mini Mental State Examination, MMSE, to get a quick gauge of cognitive function.
Appearance, behavior, cognitive function, using tools like Mini-Cog and T.
Key thought processes and perceptions. How is their thinking? Is their thought process logical, coherent, goal-directed? Or is it disorganized, tangential, circumstantial? Or is their thought content realistic? Assess for any perceptual disturbances like hallucinations, sensory experiences without external stimuli, auditory, visual, tactile, or illusions, misinterpretations of real stimuli. And critically important, assess for suicidal or homicidal ideation here as well, digging deeper if the initial safety screen was positive.
Thought processes and perceptions, including hallucination ideation. And just to clarify, the Mini-Cog is purely for screening cognitive function, right? Not for substance use or mood.
Correct. The Mini-Cog is a brief screen specifically for cognitive impairment, often used to detect dementia. It doesn't screen for depression, that's the GDS, or substance use, that's CAGE or other tools. #VF nutritional assessment.
Okay, our final domain for this deep dive application is nutritional assessment. Let's start with the very basics, the primary macronutrients. We know carbohydrates are the body's main source of energy. What about proteins and lipids?
Right. Carbs are fuel. Proteins are the building blocks. They're essential for cell structure, tissue maintenance and repair, enzyme and hormone production, and immune function. They're made up of amino acids. Some are essential, meaning the body can't make them. We must get them from diet. And some are non-essential. Lipids, or fats, are also a concentrated energy source, but they're crucial for other things too. Insulation, protecting organs, and especially for absorbing fat-soluble vitamins, vitamins A, D, E, and K. You need fat in the diet to absorb these vitamins properly.
ADEK, fat-soluble vitamins. Good reminder. And with lipids, we often hear about cholesterol, LDL versus HDL.
Yes. It's important to know the difference. LDL stands for low-density lipoprotein. It's often called the bad cholesterol because high levels can lead to plaque buildup in arteries, atherosclerosis. HDL is high-density lipoprotein, the good cholesterol, because it helps transport cholesterol away from the arteries and back to the liver. So high HDL is generally protective.
LDL, bad. HDL equals good.
Yeah.
Got it. Now, generally, nutritional problems develop over time. But when might nutritional deficits become an urgent priority? Something requiring close, perhaps even serial, monitoring.
While true nutritional deficiencies rarely develop acutely overnight, certain situations dramatically increase metabolic demand and catabolic risk, tissue breakdown, making nutritional status an urgent concern. Think of major trauma, like extensive burns, major surgery, severe infection like sepsis, or conditions causing significant malabsorption.
High stress states.
Exactly.
Yeah.
In these high metabolic demand situations, the patient's caloric and protein needs skyrocket. If these needs aren't met quickly, they can rapidly develop malnutrition, which hinders healing, weakens immunity, and worsens outcomes. This is when serial laboratory values become really important, monitoring things like serum albumin or, even better, prealbumin, which has a shorter half-life and reflects changes more quickly, helps track nutritional status during these critical periods.
Okay, monitor labs closely during high stress. When we're doing a comprehensive nutritional history, what methods do we use to find out what someone actually eats?
Common methods include 24-hour recall, asking the patient to remember everything they ate and drank in the last 24 hours. Quick, easy, but relies on memory and might not represent a typical day. 3-day food diary, having the patient record everything consumed over 3 consecutive days, usually including 1 weekend day. More accurate than recall, but requires patient motivation and literacy. Food frequency questionnaires, asking how often the patient consumes certain types of foods or food groups over a longer period, like a week or month. Good for assessing long-term patterns, but less precise about quantities.
Okay, different tools for different purposes. What else is part of that history?
You also need to assess for any significant weight changes, intentional or unintentional, gastrointestinal symptoms that might affect intake or absorption, nausea, vomiting, diarrhea, constipation, difficulty swallowing, any known food allergies or intolerances, and their use of supplements or vitamins.
Got it. Subjective history covered. Objectively, besides lab values, what physical measurements, anthropometrics, do we need to know how to assess for the NCLEX?
Key anthropometric measurements include height and weight, used to calculate body mass index.
BMI.
You need to know the BMI categories: underweight 18.5, normal 18.5, 24.9, overweight 25, 29.9, obese 30 plus. Waist circumference, measured at the iliac crest. It's a strong indicator of abdominal visceral fat, which is linked to increased risk for cardiovascular disease and type 2 diabetes. High risk is typically 40 inches for men, 35 inches for women. Percentage calculations, assessing the percentage of usual body weight, current weight, usual weight by 100, or ideal body weight, and calculating the percentage of weight change over time, usual weight, current usual weight by 100. Unintentional weight loss of 5% in 1 month or 10% in 6 months is generally considered clinically significant and requires investigation.
BMI, waist circumference, percent weight change. Okay. Finally, let's talk about collaboration. When it comes to making significant dietary changes or planning therapeutic diets for a patient, what is the nurse's role versus the role of the wider interprofessional team?
This is an important distinction. The nurse plays a crucial role in screening for nutritional risk, collecting the initial assessment data, history, anthropometrics, identifying issues like swallowing problems, monitoring intake, providing basic education, and administering nutritional therapies like tube feedings or IV nutrition.
So screening, assessing, monitoring.
Right. However, when it comes to planning complex therapeutic diets, like for kidney disease, diabetes, heart failure, or making major dietary changes or improvements, the nurse should always collaborate with an interprofessional healthcare team. Critically, this includes a registered dietitian, RD, or a registered dietitian nutritionist, RDN.
Why is the RD so crucial?
The RD has the specialized, in-depth knowledge of nutrition science and medical nutrition therapy required to develop safe and effective individualized dietary plans based on the patient's medical condition, nutritional needs, cultural preferences, and lifestyle. The nurse implements and monitors the plan, but the RD typically designs it. Collaboration is key.
Collaborate with the RD for specialized diet planning. Got it. And just a quick note on older adults and nutrition.
Yes, remember that older adults generally require decreased caloric intake compared to younger adults, mainly due to a lower basal metabolic rate, BMR, and often decreased physical activity. However, their need for essential nutrients, especially protein, vitamins, and minerals, remains high or may even increase. So the focus shifts to nutrient-dense foods. Adequate hydration is also critically important and often overlooked in this population. Hashtag tag my sex. Conclusion and final takeaway.
Wow, okay. We have covered a ton of ground in this deep dive into foundational nursing assessment concepts. We really started right at the beginning with the ANA defining our goals and the 3 levels of prevention: primary, stopping it before it starts.
Secondary, catching it early while the person is unaware.
And tertiary, managing the established illness to prevent complications. Then we built that core clinical reasoning engine, mastering the 6 steps of 8API.
Assess, diagnose, identify outcomes, plan, implement, evaluate.
And really nailing down that crucial difference between a nursing diagnosis focusing on the human response and the medical diagnosis, which names the disease itself.
Absolutely. And then we installed the safety systems using ABCDE for prioritization in emergencies, knowing those critical RRT vital sign triggers by heart.
10 or 32 RR, 92% PO2, 55 or 120 pulse, 100 or 170 SPP, 35 or 39.5 temp.
And using the SPR framework for clear, safe communication to prevent those errors. Finally, we took all that theory and applied it directly to complex assessment areas.
Right, mastering the IPPA sequence for physical exam, understanding the different types of pain and the urgency associated with some, recognizing that cultural competency starts with nurse self-awareness.
Differentiating between delirium, dementia, and depression. Those tricky 3Ds, and knowing the basics of nutritional assessment and when to call in the RD.
It's a lot. But true proficiency, especially for a high-stakes exam like the NCLEX, means you have to stop seeing these as just separate chapters in a textbook. You have to integrate them, connect them, especially under pressure.
That is absolutely the key, and that's the challenge we really want to leave you with as you study. Don't just memorize the definitions. Think about the connections. Consider this kind of ultimate application scenario.
Okay, hit me.
How does a patient's score on the MiniCog, that cognitive screening tool we mentioned, potentially influence the type of pain assessment tool you choose? Maybe that 0-10 numeric scale isn't going to be valid if their cognition is impaired, right? Maybe you need to rely more on the FLACC scale or observation.
Okay, so cognition impacts pain assessment choice.
Right. And then building on that, if that same patient is experiencing severe pain, how might their cultural belief system, maybe a belief that strong pain should be endured silently without complaint? How does that change your implementation plan under the ADP framework?
Right.
You've assessed the pain, maybe observationally. You've identified an outcome, pain relief. You've planned interventions, meds. But how does that cultural factor influence how you implement, how you offer medication, how you interpret their response?
You can't just assume they'll ask for meds if their culture values stoicism. You might need to offer it proactively based on your objective assessment, even if they don't explicitly complain.
Exactly. That's the integration. True mastery for the NCLEX lies in seeing those connections between seemingly separate domains: cognitive function affecting pain assessment, cultural beliefs influencing intervention strategies, and weaving them together into one seamless, holistic picture of your patient.
Focus on the relationships between all these concepts we discussed. Practice connecting 2 or 3 random assessment components and thinking through how they influence each other in a real patient scenario. If you can do that, you'll be well on your way to acing those application questions.
Keep that critical thinking engine running, actively look for those connections, and really, truly good luck with your studies. You've got this.